Hi, I'm Dr. Mark Student, and thank you for sharing your time with me today to discuss addictionology, low back pain, and chiropractic. First, I'd like to thank Chiro Secure for the opportunity to present on this platform, as they've always taken a very progressive role in bringing the latest information in the industry to you. So let's get right to it and put up the screen. Now, when we talk about addictionology, and addictionology is a relatively recent specialty within medicine. I was introduced to an addictionology specialist, a medical doctor. With that doctor, let me just go to the next screen, see if this will work. There we go. Okay. I was introduced to an addictionology specialist actually when I sold a building. And I owned a building, and he came in. He wanted to put addiction treatment centers in there, and I really got quite an education. He was trained at Mount Sinai School of Medicine in New York City, became an ER doc, trained at Johns Hopkins. His credentials were pristine, and he went into addictionology based upon his understanding or his experience in the emergency room watching addicted patients come in, and just it's like a revolving door over and over and over. And years ago, dealing with the State University of New York at Buffalo, Jacobs School of Medicine and Biomedical Sciences, researchers up there said to us years ago, if you could just get rid of the underlying back issue, which, by the way, is the fifth most prevalent diagnosis, we'll talk about that in a little bit, for primary care providers, then we could work on that addiction stuff. And this doctor said the exact same thing to me. But what's the core of the problem? The core of the problem is simple. There's a dogmatic understanding that non-anatomic pain, and anatomic pain is fracture, tumor, infection, and herniation. Non-anatomic pain is called non-specific. And in non-specific pain, medicine really has zero solution. So even in a recent research article last year reported, accordingly, chronic low back pain and neck pain are considered non-specific in a large majority of cases. The large majority is 98%, meaning the pain cannot be attributed to a specific origin or to a pathology detectable with imaging methods. So that dogma has perpetuated, and it's extremely, extremely problematic. But when you look at spine pain generators, here they are. The spinal cord can be a pain generator. You could see that on imaging, especially with herniated discs or tumors or infections. The nerve root itself is a pain generator. That's the nerve root which is in the neural canal exiting at the foramen, or within the canal below the conus medullaris in the cauda equina. And you can image those easily. The thecal sac. The thecal sac is the covering of the spinal cord and spinal nerves. And you too can image that as well. Then you have the disc itself. The disc has the recurrent meningeal nerve, which normally resides in the outer 1/3 of the disc. It used to be called the sinovertebral nerve. And you could really image the outer 1/3 of the disc, look to see if it's degenerated. That's easy. Then there's cord edema, which leads to myelomalacia. First is swelling, which you can image easy. And then over time, if there's swelling, it compresses the vessels, and then the nerve cells start to die, and then the cord starts to die, and you get myelomalacia. We're going to skip the next one. Now we're going to go to chemical radiculitis. When we look at chemical radiculitis, you're seeing usually a tear in the annulus, where a piece of that nucleus pulposus material comes out and contacts at some degree the nerve root somewhere, either within the canal or as it exits. All of those things are pain generators, which happens maybe in not 2%, a little bit more than that. 2% is surgical, but maybe 90% of the time. But what you can't see, or at least in medicine doesn't know how to see, is connective tissue pathology. Connective tissue pathology, which is specifically ligaments, and that's what we've heard if you lived in the personal injury world of strain sprain. It's soft tissue, it's nothing. I hate when they say soft tissue, it's nothing. Your brain, your liver, your spine, your spleen, Your spinal cord, that's all soft tissue. It's not nothing, it's something. And connective tissue in of itself is an organ, and you also have significant ligamentous issues which create problems. And it is demonstrable. So connective tissue really is responsible for upwards of 98% of back pain. And if you look at this piece of technology, which I've talked about in the past, called Symverta, on this slide, you can see that there are little dots here. And when you look at those dots, by the way, it's going to be a little disconcerting for you. For me to move my mouse, I have to look at a screen to my left. When I'm looking back at you, I'm looking this way, so I apologize for turning my head. But when you look at the screen here, you can see little dots in the corner of the vertebra. That's called X-ray digitizing. And when we digitize in flexion and extension, we look at the movement either forward and back in translation or angular deviation. And depending upon the amount of degrees that the vertebrae rotate or they translate back and forth, we get a number for that. And there are guidelines in the literature for those numbers being pathological. And depending upon which movement we're discussing, it can be the facet capsule, the ligamentum flava, the anterior longitudinal ligament, the posterior longitudinal ligament. All of those things we are getting, that's the green line for pathology, or we're looking at impairment rating, which is the red line, which is an administrative guideline of a whole person impairment. But nonetheless, this patient has no fracture, tumor, infection, or herniation. But look, it's kind of clear where this person's problem is. It's between C6 and 7. They've got a C6 and C7 problem. This is extremely specific. And herein lies the problem. Because when medicine goes back to non-specific back pain, they don't know what they're treating. So what they do is they try to cover up the problem. And that is a specific issue. So Dr. Paolo Capolo, this is what I mentioned a moment ago. Let me just read his bio a little bit. Simultaneously earned a Bachelor's of Science in Mathematics at New York University and a Bachelor of Engineering at Cooper Union, which is one of the most rigorous schools in the world, back in 1990. He completed his medical degree at the Mount Sinai School of Medicine. And then he completed his residency in emergency medicine at Johns Hopkins in Baltimore, Maryland. He's board certified in addiction medicine by the American Board of Preventive Medicine and board certified in emergency medicine by the American Board of Emergency Medicine. He's a member of the American College of Emergency Physicians, the American Society of Addictive Medicine. So the guy's well credentialed. He's got a great pedigree. He's not a lightweight, and he's just unbelievably experienced in this. And his quote when I spoke with him yesterday, "Fixing the cause of the pain is most of the battle and gives the patients hope." He said, "What good is me getting them off of their opiates if they're back to ground zero for the reason they took the opiates in the first place? Unless you fix the underlying condition, you have fixed nothing." And that was a powerful statement. And, it reminded me, listen, I'm in the game 42 years. I've been a chiropractor since actually 41 years. December, next month will be my 42nd year. But it goes back to what we always laughed about when I was in school back in the 1970s. You're a DC, doctor of cause. We used to say that all the time. You're a doctor of cause. You're not going to treat the problem. And, the immature, stupid person that I was years ago said, "Oh, great, this person's an addiction specialist. He was the one that created the addiction in the first place by giving the opiates, and now he has to fix it." Well, guess what? That's partly true, but it's not the real issue, and it's not the real truth. The truth is up until recently, chiropractic hasn't stepped up to the plate to give us the evidence in the literature and the scientific community, because MDs are clamoring for real solutions that are not anecdotal. They want to refer. They want to be able to say, hey, and right now the evidence does point to all of these things and has given us the ammunition. Listen, I have doctors that I placed in hospitals. I have doctors I placed. he's got 6 locations on Long Island. I'm placing a chiropractor in all 6 of them right now. And everything is based on the evidence, every single thing. So let's look at a typical MD primary care triage. Let's see how this works and how people end up in addiction or being addicted. Number one, they go to the primary care. 5th most prevalent diagnosis is back pain. Yet, and we're going to talk about the training on musculoskeletal care, primary care, which is virtually nothing. They order muscle relaxers, usually the treatment fails because it just doesn't work. Then they go to the surgeon. 98% of the surgical issues are mechanical and non-specific. They can't treat them. Then they go to physical therapy for the first provider. PT doesn't help for spine. PT is not a solution. We're going to talk about that as well. Then they fail and they go back to the ortho with the primary care and they go back on muscle relaxers, steroids, painkillers, and opiates. And it goes in a circle till they go to a final solution, which is the pain management doctor, which is legalized addiction. And that's a problem. And that's a huge problem. And it goes in circles so they end up there because they have no other solution. In a recent article written by Humphreys, etc., in 2007, in the United States, upwards of 25% of all visits to primary care medical doctors are musculoskeletal complaints. Yet, it has been estimated that less than 5% of the undergraduates in graduate medical curriculum in the United States and 2.2% in Canadian medical schools developed to musculoskeletal medicine. Yet 25% of their patients are musculoskeletal, but yet less than 5% of their education. The following results were published in this paper for basic competency examination in various professions. And they found that recent medical graduates had only an 18% competency in musculoskeletal medicine. Medical students and staff physicians, 20%, even osteopathic students, 29%. In another article by Rossini, Monsoon, etc., reported regarding medical providers, 92.2% believe that musculoskeletal education has not been sufficient for general medical practitioner training. They get it, they understand it. However, Whedon in 2013 reported that an annual charge per person filling an opioid prescription was 74% less if they saw a chiropractor versus an MD, a PT, etc. Whedon also reported in 2018 that there were 55% lower recipients of opiates if they saw a doctor of chiropractic compared with the non-recipient, PT, MD, osteopath, exercise rehab, acupuncture, and on and on. Then another article came out 2 years later, which is 2 years ago, by Corcoran, which said the same thing, reported that the proportion of patients receiving opioid prescriptions was 64% lower than PTs, MDs, DOs, and all other treatment. So the evidence is out there. And by the way, this one page got the attention of that addictionology specialist. But according to independent research, I lecture and speak to hundreds of surgeons around the country, orthos, neurosurgeons, pain management specialists. Only 2% of their cases require surgery. Where did the other 98% go, folks? Today's web published care path. No, this is web published. Today's web published care paths for let's talk about non-specific back pain. Let's go to 2 highly regarded institutions. The Cleveland Clinic, that talk about low back pain, non-specific issues. These patients may best be served through prompt access to care from physical therapists or nurse practitioners and entry-level providers. When pain persists beyond 4 to 6 weeks, CarePath defines when referral to spine or pain specialists, spinal surgeons, or behavioral health providers. I dealt with someone in the VA. They misdiagnosed her. They sent her to back pain school. That back pain school, which cost 5 times as much as a chiropractor would cost. It's just absurd. The Mayo Clinic. Physical therapy is the cornerstone of back pain treatment. A physical therapist can apply a variety of treatments such as heat, ultrasound, e-stim, and muscle release techniques to your back muscles and soft tissue. The Mayo Clinic does list chiropractic now. They amended it. They put it after rest, doing nothing, surgery, and then under your supervision of your physician, of your medical doctor, then you might want to consider a chiropractor after all of those things have failed. Implanting electric muscle stimulators, surgical, after all of those things. It's just beyond crazy. But the question is, where do those other 98% go? Today, we're focusing on the 98% and capturing that market share based upon the evidence and avoiding unnecessary opiate use. Physical therapy. I love physical therapy, by the way, for everything but spine. I love physical therapy, and I've worked with many incredibly great PTs. I've had my hip replaced. I needed a PT to help me to learn how to walk. Shoulders, elbows, extremities, it's great. Humphreys, in 2007, published a paper again for basic competency, and they found a passing score of 70% better on musculoskeletal conditions. Physical therapists at the master's level had a 21% passing. Physical therapists at the doctorate level, 26%. And chiropractic students, much to my dismay, was only 64%. But still, it's almost triple that of physical therapists. Now, when you talk about a doctor of physical therapy, they learn more of the same. They're not learning how to diagnose, analyze, create prognoses. They don't learn how to do those things. It's not within their training. But according to Blanchett in 2016, medicine versus chiropractic had a 12% longer disability, full disability than chiropractic. And physical therapy, if they were the first provider, had a 239% more full compensation and 313% increase in partial I said compensation, I meant disability. So a 239% increased disability to being fully disabled and 313% more being partially disabled than if chiropractic was the first provider. Cifuentes reported a 32% decrease in average weekly cost of medical expenses for chiropractic care were cheaper. And Maffei et al. Reported just managing low back pain, just managing, and this is in 2013, had a $106 billion increase. They're spending $106 billion with PTs when they have a 313% increase partial disability. It just doesn't make sense. There's 64% more opiates. It just doesn't make sense. It just doesn't make sense. So let's move on. Cifuentes reported there was a 250% decrease in disability compared to the MD with chiropractic. Day et al. Reported 82% of fourth-year Harvard medical students failed a basic competency in musculoskeletal care. Devaucher revealed that 80% of chiropractic patients exhibited a decrease in pain, verified by electrodiagnostic testing. I had another article in here which showed that 96% of chiropractic patients had satisfaction based upon pain decrease, and on and on and on and on. Here's the outcome, folks, of it perpetuating this failed care path. It just perpetuates. You live into drugs. You have no choice. You can't function. Then you get addicted or sick, and you still can't function with the drugs. But the other part of the problem is that the bones are still out of position. You've got biomechanical failure. And based upon the piezoelectric effect, which was defined, I think, about 50, 60 years ago, you get Wolff's Law come into effect, which was actually coined by Julius Wolff, I believe in 1853, where bones will remodel. Now you've got remodeling of a spine because you're trying to fix a mechanical problem with a pharmaceutical issue, a pharmacological issue. You cannot fix a mechanical problem with a pharmacological solution. There can never be, because the drug is not going to move that bone. Now, here's what Dr. Coppola stated. With the advent of an addiction specialist, they have understood and searched for a solution to the underlying cause of the fifth most prevalent reason for visiting a U.S. doctor, low back pain. And the reference is here. Addiction specialists are searching for the education of the cause of the pain that led to the opiate use initially, and chiropractic outcomes have warranted inclusion into their treatment plans for the management of substance addiction. The challenge that addiction specialists must overcome with using chiropractic is coverage issues, where Medicaid and workers' compensation system place unrealistic roadblocks. These systems in every state offer full coverage for services that realize 64% higher opiate use and a 313% increase in disability, yet still prevent patients from receiving evidence-based care that prevents opiate addiction. In New York, for instance, Medicaid does not cover chiropractic, but they cover opiates, they cover surgery, they cover physical therapy. In other states like New Jersey, Medicaid covers chiropractic at $6 a visit. It's just crazy. And in workers' comp systems, many states are now precluding chiropractic, or they've made the gatekeeper either the employer or the orthopedic surgeons for chiropractic, just like they did for physical therapy. So they're actually paying through the nose, proverbially, for a system or a program that's proof to fail. It just doesn't work. And this isn't my opinion. It is my opinion, but it's also corroborated by those in the industry all over the globe. They're looking for the cause of the problem. They'll never fix the addiction problem. Now, folks, this is only the tip of the iceberg. And it's not just people who are addicted. It's people walk around with chronic pain. Chronic pain is deemed that of which is persisted for more than 6 months. And I believe about 13% of our population in the United States walks around with chronic back pain at any given time. 13%. So if we take the population, I've got a calculator working off to the side, times 0.13 equals, you're talking 45.5 million people are walking around with chronic back pain. Now, right now in the United States, it's reported about 50,000 actively practicing chiropractors. There's not unreported actively practicing. I don't. So, but let's be real, okay? So if we take 45 million and divide that by 50,000, that means every chiropractor should be treating an extra 910 new patients every year just for the chronic, non-specific back pain patients in this country. Can you imagine that? Every one of you would have a closed practice. Everyone would have closed practices. It's just incredible. It's just unbelievable. This country is spending $106 billion a year for a failed pathway of treating chronic pain. And I know we're talking about pain, and some of you might be more inclined, you want to treat systemic issues and colitis or breech babies and eczemas. I don't really care what you do as long as it's within your lawful scope. But let me share something with you from someone who used to do that at a very high level. Patients are trained right now and accept chiropractic for back pain. I don't want to pigeonhole you as a back pain doctor, but I don't care why they come into your office. You can educate them any way you want. But if they don't come in your office, what good is having all this wonderful theories and philosophies and experiences and helping people? I've seen miracles in my office through the years. I mean, really, truly miracles. And I have to tell you, my practice took off when I stopped marketing, advertising, or just focusing on those miracles with the average patient in the street. I started talking about back pain and neck pain. And the next thing I knew, my practice took off. And then while those patients are in my office, I would educate them, and they tell their friends, and they oh, Dr. Stu, do you know he helped all these people with asthma? The next thing I knew, those back pain people referred dozens of asthma patients into my office. And guess what? They threw their medicine out also. It's not that I treat asthma, I treat the underlying cause. They didn't need the drugs anymore in those inhalers. Just like this doctor, Dr. Capolo, says, I don't give a crap what you do to them. If you fix their underlying problem, I can help them throw away their drugs. But if you don't fix it, I'm not helping them throw away their drugs. And it doesn't matter what condition you're doing that for. And again, if you're looking for an evidence-based pathway, and I am a big evidence dude, if you're looking for an evidence-based pathway, this technology, Symverta that we talk about, this technology right here will tell you exactly where that lesion is. Because folks, truly and really, it's very specific. It's very easy to see. It's very easy to do. And all you need is a simple x-ray. And let me clear up one myth. X-ray has, regardless of the political rhetoric from our national organization, singular, X-ray has no negative side effect. Zero. In order for you to have a side effect of an X-ray, a negative side effect, you would need to take a minimum of 52 lumbar X-rays in any one setting or at any one given time. Because also X-ray is not cumulative. So if you take an X-ray today and a month from now and a month from now, it's not cumulative. And that's not my opinion. It's right from the evidence of the literature. You need 100 millisieverts at any one time of radiation, and that's a radiation dose, to have a negative effect. And a negative effect means less than 1 in 100,000, which is still on of itself almost nothing. A lumbar X-ray, I believe, has 1.52 millisieverts of radiation. So you need like 52 or 54 lumbar X-rays just to have 1 in 100,000 issue. And in fact, X-ray serves to be an anti-carcinogenic property in many human cells. There are zero, zip, not a zilch, in the totality of the literature. And some people say, well, let's go back to Hiroshima and look at that radiation. My goodness, I've heard that crap until I want to vomit. The amount of radiation is like thousands of millisieverts from that. That's not what we do in a diagnostic clinic, in a chiropractic office. You can't hurt your patient by taking an X-ray. It's just not possible, okay? Based upon the evidence in the scientific literature, it's not my opinion, and it's all over the literature. And that's according to the American Society of Medical Physicists, Radiation Physicists, and a myriad of other things. So you really need the evidence. Simple X-ray. Look at how much the bone moves. You can see what ligaments are now pathological. You have very specific back pain. This picture right here is the cause of many doctors getting hundreds and hundreds of referrals from surgeons and medical primary care providers because they can see based upon the evidence, and what I'm sharing with you is all evidence-based. This graph right here is based upon what's in the literature. It's all evidence-based. It's all there. Listen, I could go on and on and on and on, and I really would love to. So if you have any questions, I'd love to hear from you. Give me a jingle. I'm Dr. Mark Student. We're from the Academy of Chiropractic. If you have any questions, you want some research, you want to take courses, just go to the academyofchiropractic.com. Again, I would like to thank ChiroSecure so much for giving me the platform to share this with you. I've been doing it for quite some time, and I like it. So I'm going to keep doing it until they tell me to not to come anymore. So listen, thank you so much. See you next time. Have a great day.